yes.
Before it, sir, Kishorji, can you please make a count? Then Dr. Ganguly sir will start.
Yes, yes.
Okay.
Sir, we're going to log in now. 10 seconds, sir. 10 seconds.
Okay. 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 Good afternoon, everybody. Dr. Mondal and our presenters.
Good afternoon, sir.
And Dr. Manjuran, good afternoon. Dr. Manjuran, Dr. Ghosdosdar. They are yet to join. In any case, we shall start.
Good afternoon, sir. Good afternoon, sir.
Who will be first, Ranjini? Who will be first? Start presentation of our case.
Okay, sir. Sir,
Yes.
is the slide visible?
Yes, start.
Yes, sir.
Kindly make full screen, madam. Next, yes.
Good afternoon, respected teachers.
No, still we can see as it's not in presentation mode.
Okay, sir.
You can able to see full screen.
Yes, sir.
While sharing, select the screen, share screen.
Yes,
Select
sir.
your full screen option.
Okay.
Before sharing, select your full screen option, then share.
Right. Full screen working. PowerPoint slides.
Or else you can select complete desktop.
Sir, now is it okay?
No, kindly stop share. I'll tell you. Kindly stop share.
Okay. Stop sharing.
Click share screen.
Yes, sir.
Yeah.
You can able to see screen.
Am I audible?
Screen or desktop.
Yes.
Yes.
Good afternoon.
Good afternoon.
Entire
Good afternoon,
screen.
sir.
Entire screen. Then share.
Entire screen, then share. We are doing the same.
Hello. Screen share again.
Yes, sir.
PPT to the.
Sir, screen share.
It is loading.
Hello. Hello.
Yes, sir. Yes, sir. You're audible, sir.
Am I audible?
Yes, sir. Yes, sir.
Yes, sir.
New share.
It is still loading. Yeah. Now switch to your PPT. Minimize this window. Yeah. Now perfect.
Okay.
Dr. Ganguly sir. Dr. Ganguly sir.
Hello.
Dr. Ganguly sir. Dr.
Yes, yes.
Manjuran. Dr.
Recording
Manjuran sir.
stopped.
Dr. Manjuran sir and Dr. Dipankar Ghosdosdar sir both have joined.
Okay. Good afternoon, sir.
Good afternoon. Good afternoon. How are you?
Fine.
Good afternoon, sir.
Recording in progress.
recorded.
Please start, madam.
Okay.
Good afternoon, teachers. Sir, today we will be presenting a case of organic tricuspid regurgitation unraveling to carcinoid syndrome. So our patient
Sir,
is.
I'm just asking. The discussion is for 1.5 hours. This
Yes,
is only
yes.
one case.
Yes,
Okay.
sir.
Yes.
Okay. Go ahead.
Yes, sir. Sir, our patient is 80 years old male patient who presented to our OPD with complaint of easy fatigability for last 6 months progressive weight loss for last 6 months, and swelling of bilateral lower limbs for last 3 months. So when we took detailed history, we got to know that the patient was apparently well 6 months back. For last 6 months, he has been experiencing easy fatigability, and it was so severe that he lost all enthusiasm to go out to the market or for a walk. He started staying inside the home, and gradually his life got limited to activities of daily living only within the house. And he tried to gain strength with healthy diet, good sleep, and vitamin supplements, everything, and the lifestyle modifications. But there was slight or no improvement, and he never experienced breathlessness. He tells that he was never short of breath, but he was losing all the energy to carry out any activity. Besides, he noticed that his body weight was gradually decreasing, and initially he thought because he is not eating well, that is why he is losing weight. But he could hardly reverse the ongoing process by increasing food intake or improving rest, having good sleep. Meanwhile, he also noticed that his bilateral veins are getting swollen every evening. In the morning, it used to disappear, but in the evening, he was having the bipedal swelling, and later on, it increased and it started persisting throughout the day and night. And he never had any history of fever in last 6 months, no history of joint pain, chest pain, palpitation, dizziness, or syncope. So, in history of past
Just
treatments,
I'm requesting the host to turn on my video. I'm not being able to turn on my video because the host is denying me.
No, sir. 1 minute, sir. I'll check.
sir, should I continue?
Yes, yes.
Yes, please.
Yeah, you
Yes,
continue.
please.
In history of past illness, the significant thing was he is a known hypertensive, and he was taking regular medications for past 20 years. And apart from that, in 2014, he underwent a health checkup because he was employed somewhere, and they asked to carry out that. And in that, he was detected with some liver lesions, and that was not considered significant by the doctors, and there was no further workup done. And in personal history, we got he had no addiction of tobacco, alcohol, or anything else. He's a married man living with wife and 2 adult sons in apartment, sleeping pattern. And in treatment history, he has been on multiple antihypertensive for last 20 years. And he doesn't have any drug allergy, chemotherapy, history of undergoing chemotherapy, dental or surgical procedures. So based on the differential diagnosis, we first considered the following
Sum up your case,
possibility.
Ranjani. To sum up your
Yes,
case.
sir.
Sum up.
Yes, sir.
In short.
Yes, sir. The patient, 80-year-old elderly man, presented to us with easy fatigability and bipedal edema and history of recent weight loss. And in his history, there was no history of breathlessness or any chest pain or dizziness, palpitation. And in past history, we got to know that he has been hypertensive for a long time, and he based on these findings, we can conclude that he might be having a chronic heart failure. He can have similar findings in cirrhosis of liver or chronic kidney disease also. And considering his age and findings, weight loss, and this easy fatigability, we can consider malignancy also.
So, what is chronic heart failure?
So, chronic
It is
heart
congestive
failure
heart
is,
failure, left heart failure, or biventricular failure?
sir, in his case, we will think about right heart failure.
Okay, that is also congestive heart failure. Then any pericardial disease?
Sir, considering the history, it can be pericarditis.
Pericarditis? Which pericarditis?
No, sir. There is no history of chest pain. So,
So, can it be constrictive pericarditis?
Constrictive pericarditis can mimic this situation.
That's not written that way. Yes, chronic liver disease, we agree.
Yes, sir. Constrictive
Chronic-
pericarditis.
You have just given a history of
Sir, sorry to disturb you. Sorry to disturb you. Sir,
just given us a history of classical right heart failure. You have said that there is easy fatigability, there is pedal edema.
Uh, I want to ask a question to the student. How can you think of cardiac disease in this from this story?
Yes, am I audible?
Divankar, you are poorly audible. Your voice is breaking up.
Because, sir, in patients with heart failure, we often get the patient is having like a diminished exercise capacity and fatigue. Since he is an elderly man, he might have like stopped doing activity. That's why he did not understand that he is having exercise intolerance. So it can.
Now,
I
see,
thought it can be
this
part
patient
of
is
heart.
this patient is hypertensive and has been
Yes,
having progressive loss of weight and progressive deterioration in his exercise capacity. I would have started thinking that maybe more likely to be that it is a renal disorder than cardiac disorder. Because
yes, sir. It can.
and if it is a cardiac illness, which side is the heart is affected? Is the right sided disease, left sided disease, both sided disease?
Yes, sir. It can be.
Whether it is a right sided disease,
What
left
do you
sided
think?
disease, or a both sided
Sir,
disease.
this is more more towards right-sided heart failure, because in left-sided heart failure he could have like paroxysmal nocturnal dyspnea and mood dyspnea. Here mostly we are seeing that he has fluid overload and
So,
bipedal edema and
so in an 80-year-old person presenting with right heart failure, what are the conditions that you should think about?
चले जाइए कल.
A person, 80-year-old gentleman is presenting with right heart failure. So what are the conditions that you would like to think of?
yes, sir.
First of all, you tell me this, 10 conditions where the patients can present with right heart failure with no left heart symptoms.
With Lou. Sir, can you repeat the question, sir?
Yeah, the question is, can you mention few conditions where the patient can present with a pure right heart failure with no left heart involvement?
Yes, sir. So
At
in
least six conditions where it can be a left heart, right heart involvement with no left heart disease.
okay. So in we can think of a few conditions like valvular um, heart disease.
What valvular
Uh,
heart disease?
sir, pulmonary uh, uh, pulmonary sclerosis or stenosis. Uh,
80-year-old,
tricuspid.
80-year-old person presenting your first diagnosis pulmonary stenosis.
No, sir. If I consider like in general, I would be in this situation. We can be thinking about CKD, chronic kidney disease, and chronic liver disease. The conditions will lead to volume overload.
No, that was not the
First,
question. I asked a question. Which are the conditions in the heart where the patient
yes,
can present with right heart failure, just like him? Tell me the
yes,
condition where there's a pure right heart failure.
okay. So in case of
What
Constrictive
happens in
pericarditis.
chronic or pulmonal?
Constrictive
yes, sir.
pericarditis is one condition
Yes.
where the patient can present with pure right heart failure. So
Sir,
similarly, what are the conditions? Can you mention few conditions?
sir,
Let's see cardiomyopathy.
sir, in case of carcinoid syndrome, we can see purely right-sided.
How many carcinoid syndromes that you have seen in your experience?
Yes, sir. And
See, where rare conditions, you should bring it to the
Yes.
bottom of the list. Even if
And
you know that the patient that you are presenting is having a carotid syndrome,
You
in discussion
started
you should bring it to the
valvular heart
bottom of the
disease.
list.
So
yes,
why don't you say some causes of valvular heart disease?
yes, sir. Rheumatic, some
Yeah. Okay,
rheumatic.
rheumatic heart disease with significant
Yes, sir.
tricuspid valve disease. Okay, 3.
And valvular heart disease due to rheumatological conditions.
Eh? What?
Rheumatological conditions like ACLE and rheumatoid arthritis.
Does that denote tricuspid valve or some other valve?
No, sir. I thought you were asking causes of valvular heart disease.
No,
In
no, no,
right,
no. I didn't ask that question. I asked a question. What are the conditions in which there can be a pure right heart failure? Mention few.
sir, I can I can remember of core pulmonale we see very commonly in our wards, chronic core pulmonale and endomyocardial fibrosis.
It is not very clear. What did you say?
Sir, core pulmonale, core P, core pulmonale.
It's a lot of
Yes,
reverberations. I am not able to clearly understand what you are talking. Okay, you said about cardiomyopathy. Did you say
Sorry,
cardiomyopathy?
sir, Pisimandal, sir, you are near to those system, so that's why echo is coming.
Okay.
If you can shift somewhere near little, make distance, no, then it will be clear.
Okay, I'm keeping at a distance. All right. Okay. Okay, so tell me, if it is cardiomyopathy, what cardiomyopathy?
sir. I told core pulmonale and endomyocardial fibrosis,
Restrictive cardiomyopathy. You could be this restricted.
restrictive cardiomyopathies.
We
Yes,
are
sir.
at this age, 80-year-old person. What is the restrictive cardiomyopathy which can present at this age?
Sir, amyloidosis, cardiac amyloidosis
Very,
can
very
be
good.
there.
Cardiac amyloidosis should be considered. So, cardiac amyloidosis, restrictive endomyocardial fibrosis is usually presenting at this age. Suddenly, with for 6 months story, is a bit unlikely. They may be having symptoms from a longer period, so that's a bit unlikely. But the amyloid disease, the restrictive cardiomyopathy, amyloidosis is a possibility. Okay, next, another few more conditions. Did you mention constrictive pericarditis?
Yes, sir.
Okay. Then what else? Can this be ASD?
Atrial defect. Yes, it can present late also.
Sometimes patients with ASD can present at a later life. Okay, ASD can also be considered. Do you think this can be Epstein's anomaly?
Yes, sir. Epstein can present at any age.
Yes. Epstein's anomaly, when they start developing right heart artery dysfunction, they may present with right heart failure.
Yes,
Any
sir.
other condition in your mind?
Sir.
Right atrial tumors?
Yes, sir.
A
Right.
large,
RA masses.
large right atrial tumors which fill the
Right.
right
Yes, sir.
atrium. Sometimes they present with right heart failure. Any other
Yes,
condition?
sir.
See, as a DM student, you should think of all the rare conditions. And of course, I agree with you
Yes.
that you can also think of carcinoid, which is not a very common condition, but a rare condition which can also be taken into differential diagnosis. Okay,
Yes.
out of these,
We,
which you think is the most likely?
Sir, in this case, according to history and examination, we think that it can be chronic kidney disease, chronic liver disease, heart failure, and can be constrictive pericarditis also, or can be any congenital heart disease like ASD or Epstein anomaly. And we are also thinking about right atrial masses and infective endocarditis. Really, it can be like in rare occasion, it can be right-sided infective endocarditis also.
Especially
But
in
he is not. Okay.
say,
See,
especially
one he has got progressive
Why
loss of
there
hearing.
is, sir, I'm just asking one question. Why there is increased fatigability in your case, but no dyspnea?
Sir, the patient might be, what I thought, that patient might be anemic due to some reason. Maybe due to renal cause or nutritional deficiency.
Doctor, easy fatigability.
Can you tell us any cardiac cause of increased fatigability relevant to this case?
Yes, sir.
Why the patient is having increased fatigability?
Yes, sir. The patient is having easy fatigability and also weight loss and bipedal edema. Considering the context, we can think of some chronic diseases like chronic kidney disease, chronic liver disease. Patient might have anemia, chronic heart failure, or any malignancy. All of this can cause easy fatigability. He might have ischemic heart, restrictive cardiomyopathy,
Doctor,
or
Doctor,
As sir is pointing out, sir is repeatedly telling you that we are considering right heart failure as the cause.
sir, you are not audible properly.
Sir, I'll stop your video so that it may audio may get better because there is no network from your side.
Right heart failure can cause increased fatigability.
Sir, your voice is breaking, sir.
Dipankar, switch up your video.
Doctor, easy fatigability, cardiovascular system is concerned. It is a symptom due to what?
And right heart
Doctor, what is easy fatigability?
Dr. Dipankar sir, Dr. Dipankar sir, you are not audible properly, sir. You are not audible properly. Your
Easy fatigability, as far as the cardiovascular system is concerned, is a symptom of what? Why there is a symptom of fatigability?
Because the patient is not being able to increase the cardiac output with activity that may cause easy fatigability, exercise intolerance.
Easy fatigability is a symptom of the reduced blood supply to the exercising muscles.
Yes, sir.
When the muscles get less blood supply, what happens? They even go for anaerobic metabolism, and the
Yes.
lactic acid may accumulate and reduce. Of course, it is reduced cardiac output, but the mechanism is reduced perfusion of the exercising muscles. When there is a symptom, you should know why there is a symptom. The symptom of fatigability in a patient with heart failure is because of the reduced perfusion of the exercising muscles.
Yes.
So this patient has got loss of weight, he has got become so if you are thinking that this could be a malignancy also, then do you think that in the sometimes the diagnosis that you have mentioned, there is one which can actually have malignancy and give rise to cardiac symptoms?
Yes, sir.
Which one?
Sir, malignancy. Yes, sir. Malignancy can also give cardiac rise to cardiac symptoms like neuroendocrine tumors can give rise to cardiac symptoms. Apart from that, any malignancy can cause anemia and hypoproteinemia due to inflammation, and that can lead to like various
Carcinoid, is it a malignant process which ultimately results in cardiac involvement?
Sir, yes, sir. Because of this,
how does it happen? How does it happen?
Because of the metabolites of all the vasoactive substances that are being released by the tumor.
From where? From where?
Sir, from the primary tumor.
Usually,
Am I audible now?
Yes, sir.
Yes, please respond to sir. What is sir is asking?
No,
you are thinking of carcinoid, no?
Yes, sir.
So, when does carcinoid affect heart?
Sir, when the carcinoid is in like bronchial, in case of like lung involvement in carcinoid involving lungs, and also it can like involve the heart directly. And otherwise also if it is ileal or jejunal, then also the vasoactive substances can like
Doctor, when the lung is involved, which side of the heart is affected because of the carcinoid?
Left, sir. Left
Left
side.
side. Here you are right side symptoms. Then why do you go for the lung involvement? Lung involvement actually can predispose for the left side involvement in a carcinoid patient. But in a,
I think,
but
sir,
that is very rare. But in a carcinoid patient, what is the reason of right side disease?
sir, maybe the metastasis from liver.
Yeah, that's it. They usually get metastasized in the liver,
Yes, sir.
and the active the metastasis active
Me-
tissue can release carcinoid the serotonin, and that can result in carcinoid growth.
Yes,
So
sir.
it
They
is
should
a metabolic
they should
malignant
bypass this.
metastasis in the liver. It's a malignant.
Yes, only when there is liver metastasis, the amount is produced in such amount that it cannot be metabolized by the liver. Okay.
Yes, sir.
So that is the time when the serotonin cause this deleterious effect on the right-sided valve.
Yes, sir.
You are also correct. Left-sided valve may be affected. Can you tell us one mechanism by which left-sided valves can be affected? You told us about bronchial carcinoid. Any other mechanism by which the left-sided valve may be affected from liver metastasis?
Sir, if there is ASD or PFO, then also the left-sided valves can be affected.
Very good. Very good.
No. How can your PFO left side can be affected?
Sorry, sir, your voice is not clear.
No, how can the left side be affected if there is an ASD?
Sir, in atrial septal defect with Eisenmenger, if there is pulmonary associated pulmonary arterial hypertension also, then it is.
No. Don't tell ASD. In a PFO,
Yes, sir.
PFO, there is a right to left shunt. So let
Yes,
us
sir.
all be clear. ASD
Yes,
is
sir.
usually left to right shunt. Okay.
Yes, sir.
But if there
Yes,
is a PFO, there can be a right to left shunt during episodes of Valsalva. So that
Yes,
is
sir.
when the right to left metastasis can occur.
Yes, sir.
Okay, can we go to the clinical findings?
Yes, sir.
Let's hear the clinical findings.
Yes, sir. Sir, the clinical examination part will be discussed by Dr. Debarchona.
Good afternoon, sir. I am the second presenter. I'll be talking on the discussing on the examination part. Coming to general examination, this is an elderly male who is a weight of 52 kg and a BMI of 21 kg per meter square. He has no pallor, no cyanosis, no clubbing, no icterus. He has bilateral lower limb pitting edema of grade 2, and his JVP was elevated. It was measured of 12 centimeters of water, and the prominent wave was a V wave, sir. Should I proceed, sir?
No. Question.
No. Just
what are the
wait
conditions?
on the JVP. Yes,
Yes,
sir.
sir.
Am I audible? Hello.
Yes, sir.
Yes,
Yes, sir.
yes, Dipankar, audible.
See, you have written only the V wave. A wave is not prominent. The patient is in sinus rhythm.
Patient is in
And
sinus
you have
rhythm,
not
sir,
commented
but
about the descent.
sir, I wasn't able to ascertain about the descent part, sir. The only wave I could make out was V wave, sir.
Okay,
It
theoretically,
was a
what do you
very,
expect?
it was
The
a very
JVP to be in
prominent
this
positive
patient?
wave. I could only make out V wave, sir.
Now,
you could make out
theoretically,
only one wave you think is the V wave.
Yes, I could only make out V wave, sir.
You could not clearly see any other additional wave. So that's right. You could see
Yes,
one
sir.
prominent wave which you think is the CV wave or a V wave.
Yes, sir.
And what about the Y descent? After the V wave, you can see the Y descent. You have to mention about the Y descent.
Yes, sir, but I wasn't able to ascertain whether I couldn't see it I couldn't ascertain whether there was a descent or not, sir.
What do you mean by that?
This case, Y descent is very important in this
Yes,
case.
sir. Yes, sir. Yes, sir.
So, what kind of Y descent do you expect in this case?
Very rapid
Based on the
Y
history
descent.
only.
Very rapid
Pardon?
Y descent, sir.
Why did you
Rapid
say
Y descent.
why did you say
If you get a slow Y descent,
There can be concomitant tricuspid stenosis also, sir, along with regurgitation.
Yes. So if the patient is having associated tricuspid stenosis, the
Yes,
Y
sir.
can be a shallow or a slow Y descent. While
Yes, sir.
in a patient with significant tricuspid regurgitation, there can be
Yes.
a rapid and very prominent wide descent. Usually, you will
Yes,
be
sir.
able to see a very clear-cut wide descent in a patient with significant tricuspid regurgitation.
Yes, sir.
What are the? Can you mention 5 conditions where there can be prominent V wave in the neck? 5 conditions. No. Doctor, are you hearing my question?
Yes, sir. Yes, sir. I heard your question, sir.
5 conditions where there can be prominent V wave in the neck. That's not a very tough question. It's a DM student, it's a very simple question. Can there be a prominent V wave in ASD with MR?
Yes, sir. ASD.
ASD with MR, there can be a very prominent V wave in the neck because the MR jet can sometimes even travel towards the right atrium. And also,
Yes,
it can be a very prominent V wave in the neck. Another condition can be, have you heard of Garbody syndrome? Garbody defect,
Yes.
LV to RA shunt.
yes,
Have
sir. But
you heard
I,
of LV RA shunt? Any other condition where they can
You are aware of Jarbot, na?
Garbody defect?
There
yes,
is
sir.
a
Yes.
gooseneck deformity,
Yes, sir. Yes,
and
sir.
there is shunt from LV to RA.
Yes, sir.
Can
The
be
form of VSD.
Garbody defect, there is an LV to RA shunt, there can be prominent V wave.
Yes, sir.
Any other condition? Ruptured sinus of Valsalva
RSV.
Yes, sir. Yes, sir.
into the right atrium. Sometimes
Yes.
can give rise to a prominent V wave in the neck. Again,
Yes, sir.
in a patient with coronary cameral fistula in the right atrium, a large cameral fistula in the right atrium, you may be able to see prominent V wave. So there are a number of conditions in which you can, of course, the commonest condition is regurgitation.
Yes, sir.
Okay, go ahead.
Okay, sir. Pulse was 80 beats per minute, regular in rate, rhythm, and volume. There was no special character. All peripheral
I'm
pulses
just
were.
asking you in JEP,
Yes.
did you get Kussmaul sign positive? Do you expect Kussmaul sign in this kind of case?
First of all, doctor, tell me what is Kussmaul sign. Then you say whether it is possible or not. What is
The,
Kussmaul sign?
you normally during inspiration there will be a rise in less than like um,
What did you say?
I said in like during inspiration there will be a transient rise in the JVP in normal individuals, but it will be a transient rise and a fall. But in case of like constrictive pericarditis, there is like a persistent the rise of the JVP is persistent. So um,
In a patient with constrictive pericarditis, during inspiration, there is an engorgement of the jugular venous pressure, which is
yes, sir.
unlike the normal one where there is a drop in the with the
Drop in the
good
pressure.
inspiration. Because why there is a drop? Because the thoracic pressure comes down,
Intrathoracic pressure comes down. Yes, sir.
that will be sucked into the thoracic intrathoracic cage, and there can be a drop in the jugular venous pressure. While the opposite happens in constrictive pericarditis, the same thing can happen in restrictive cardiomyopathy also, and
Yes, sir.
that is Kussmaul sign. The doctor is asking you, is there a Kussmaul sign? Do you expect it? Do you expect Kussmaul sign in this patient? In him? In this patient? Is there a normal reduction in intrathoracic pressure in this patient? Is there a possibility that during inspiration, what can happen?
There will be increased venous return in to the right side of the heart. Right
Yes.
atrial pressure will increase.
Yes.
So it can be there, sir.
What situation? When the
Yes,
more
sir.
blood is coming into the right atrium, normally what happens to this blood? It drains into the blood. So you have to think of a situation where the extra volume of blood coming to right atrium cannot be immediately delivered.
Tricuspid stenosis, yes, like in where the right atrial pressure is more than the right ventricular pressure, then in like tricuspid stenosis we can see. Sir.
In a patient with tricuspid stenosis, you can see sudden engorgement when more volume of blood is coming to the right atrium. Another situation.
Restrictive cardiomyopathy, constrictive pericarditis, and
No. In this patient, we are not
yes,
talking about the conditions where there can be Gusmore sign. If the patient has got a severe right failure, right ventricular.
yes, severe right heart failure. Yes.
If the patient has developed right ventricular failure, then extra volume of blood coming to the right atrium cannot be accommodated to the right ventricle. The jugular veins
Yes.
go. So it's very important for you to look for that. That will help you to make out whether the patient is in right heart failure or
Yes.
having associated tricuspid valve stenosis also. Okay, go ahead.
Yes. Okay, sir. Blood pressure was of 110 by 70 millimeters of mercury.
Doctor, you are
Yes,
from
sir.
which institution?
Sir, I am from the same, sir, Apollo only, sir. I am also the DRMB cardiology resident.
Apollo, West Bengal.
Yes, sir. Kolkata, sir. Yes, sir.
Okay, Calcutta. Okay, go ahead.
Yes, sir. Blood pressure of 110 by 70 millimeters of mercury in bilateral upper limbs. Respiratory rate of 14 beats per minute, 14 cycles per minute. Temperature normal. There were no palpable lymph nodes in cervical, axillary, or inguinal.
Is there a pulsus paradoxus? Is there a pulsus paradoxus?
Why pulsus paradoxus is important? Will you search for it? And how will you search for pulsus paradoxus?
So while checking for the blood pressure, we increase the blood pressure first to more than the definition is that there will be a systolic drop of more than uh, 20 millimeters of mercury during inspiration.
No. Doctor, what did you say? How much should be the drop?
10.
10 millimeters of mercury.
But you said, sorry, you said initially 20 wrong.
Yes, sir. I was wrong. Sir.
More than 10.
More than 10 during inspiration, and that is normal. In normal individuals, it should be less than 10, but the paradox is that there is a fall of more than 10 during inspiration.
No, what is the paradox? Is it the paradox? Why is it called pulsus paradox? What is paradoxical about it? Why it is called pulsus paradoxus? Actually, it's a misnomer. The heart is beating, you get the heart sounds, but you don't get any pulse.
Yes.
In that range. Okay. So that is the paradoxical about it. But it is just an exaggerated response only. Okay. So sir is asking about pulsus paradoxus. So do you expect pulsus paradoxus in this case?
No, sir.
What is the mechanism of pulsus paradoxus? What is the mechanism? Why there is pulsus paradox? It is an exaggerated phenomenon. Normally itself, during inspiration, there is a drop in the LV filling. So pulsus paradox to what?
See, first of all, this is a case of right heart failure. So these are all the things we need to know in the general survey. Number two, sir is actually looking for signs of ventricular interdependence.
Yeah.
So whenever there is constriction or restriction, the combined ventricular volume is fixed. In constriction, the entire heart is inside a cage. So if you increase the RV volume, your LV volume is going to be compromised.
Yes, sir.
Okay. And vice versa. In restrictive cardiomyopathy, this is to some less extent. But in cardiac tamponade, because there is fluid around it, again, the heart is filled with a fluid. So again, there is ventricular interdependence. So if you increase the RV volume by any means, the LV volume is going to be compromised because of the septal shift. And so that is why the LV output decreases. In deep inspiration, you are drawing more blood into the RV. So that caused the septal shift towards the LV. You can call it as the reverse Barnum effect also. So that compromises the cardiac output. Okay.
Yes, sir. Yes, sir.
And also you can
Okay.
in patients with constrictive pericarditis, especially if there is a fluid in the pericardium. That also is another condition, but the condition where you can have pulsus paradoxus is cardiac. Okay, go ahead, doctor.
Okay, sir. Okay. Coming to systemic examination, first I'd like to
No,
examine
just
the
a minute. The pulse also, this pulse, whatever you say, this is an 80-year-old patient, but all the pulse, there is no evidence of any arteriosclerosis. The arteries are not palpable, and you see the BP, what you have written is 110/70. Sometimes in this elderly population, we expect a little bit higher pulse pressure. So be very careful during examination. Okay. So they should be all properly measured. Okay. Okay. Go ahead.
Doctor, I want to ask you a question. One of the examiners just now asked you that in a patient with atherosclerosis, we find elevated systolic mechanism. What is the reason?
So because of arterial stiffness, arteriosclerosis, sir.
Which vessel is stiff? Which vessel? Is it the peripheral vessel? Is it the
Central circulation or peripheral circulation?
medium vessel or aortic central aorta, or where is the
Stiffness more in central circulation or peripheral circulation?
Peripheral, sir.
No, central.
central? Peripheral, actually, there is a significant vasodilatation, and central circulation, there is a stiffness, and that can give rise to very high systolic pressure and very low.
Conduction of pulse will be very fast.
Why pressure is a feature of atherosclerotic changes? Okay, go ahead, doctor. Present. Diagnosis. Go ahead.
Yes, sir.
You please go ahead.
Yes, sir. Coming to cardiovascular system examination, on inspection, chest was symmetrical with no abnormalities appreciated over the precordium, no distended veins, scars, and sinuses. Apical impulse was not seen, and there were supraclavicular pulsations seen by
Wait a bit. Did you carefully look for, because you have seen a prominent V wave in the neck? So in the precordium, what are you expecting?
bulging of the precordium, sir.
Yeah, but not bulging. Bulging will happen only if the right ventricular enlargement happens before the fusion of the rib. So bulging is not that usually occur in very children with a large.
You can expect epigastric pulsations. Okay, epigastric pulsations. This can be there sometimes.
Yeah. Usually,
The
you
epigastric
must.
pulsations, actually, I elicited that in palpation, sir. Inspection, it was not visible, sir.
No, if the parasternal pulsations, the precordial pulsations should be carefully looked for, because you are expecting the dilated RV in this patient. And you
yes, sir, but in this patient, there was no no parasternal pulsations, no palpable any heart sounds, no, sir. The only pulsation was seen was the supraclavicular pulsation. That was
so in one word, what is your inspection or palpatory findings are suggesting in background of this case? What you can rule out as a cause of right heart failure in this patient, just by your
pulmonary
palpation?
hypertension, sir.
Yes, go ahead.
And did you look for prominent pulsations in the third left intercostal space?
Yes, sir. There were no pulsations, sir. On palpation,
What is the pulsation that you get in the third left intercostal space? What is the pulsation that you get in the third intercostal space? Without understanding what are you looking for, there is no point in looking for. So, what is the situation where you can get a prominent third left intercostal? It is usually when the RV outflow is dilated. When the RV outflow is dilated, you will be able to significant pulsations in the third, and 2-3 conditions where there can be prominent outflow dilatation are One, in patients with Epstein's anomaly. Two, in patients with RV endomycal fibrosis. There can be prominent RV outflow pulsations in large AST patients. It can also be present in patients with severe tricuspid regurgitation, organic tricuspid regurgitation. So if
Okay,
you're
sir.
expecting organic tricuspid regurgitation in this patient, you should have carefully looked for the pulsations in the third left and space. And if it was not present, you should mention it. Because once you mention it, examiner knows that you are knowledgeable. Your knowledge should be exhibited. So
Yes, sir.
you did not know that it is important to look for third left in the space pulsations. Okay, go ahead.
Okay. On palpation, I found the apical impulse was hyperdynamic in nature and it was felt in the left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line. Again, I confirmed the bilateral supraclavicular pulsations and also epigastric pulsations were felt, sir. No other palpable hearts like sounds, thrills, or heave was appreciated, sir.
No,
No other
no.
pulsation.
No. Come to the apex. Come to this
Yes, sir.
apical finding. What kind of apex you are suggesting? Because you have to comment. Is it LV type? Is it RV type? And it is hyperdynamic. And
Yes,
there
sir.
is cardiomegaly apparently from your apex, what it looks like.
Yes, sir. And
So what kind
it's,
of apex is this?
It is shifted down and out, sir. It looks more of like a LV apex because in case of RV apex, in severe right heart failure, if there is enlarged RV, usually it can be felt more near the lower left sternal border.
How can you differentiate RV apex from LV apex? By palpation.
Doctor, see, when you are failing the apex speed, as you have been asked the question, how will you make whether it is LV or RV? This is a very simple question for a DM student. It's not a very tough question.
So in case of RV apex, it will be retractile in nature, sir.
And in LV apex?
No. You clear your concept about apex. Okay. LV apex is localized. Okay. LV apex is localized.
Yes, RV
And
apex
it
is
may be
diffuse.
forceful, ill-sustained or well-sustained, whatever, it is a localized.
Yes, sir.
And there is medial retraction.
Hmm.
In RV apex, it is more diffuse in nature. It is sometimes continuous with the parasternal pulsations. Okay. And there is
Yes.
lateral retraction. So in the exam time, you have to say all these points. It's
Yes,
very basic question. You have to answer this question.
The simplest method is that if the pulsations are felt only at apex, and as you try medially, the pulsations do not, they die out, and there are no parasternal pulsations, that is purely LV impulse, LV apex. Second is, as you trace medially, the impulse becomes more and more prominent. And in the parasternal region, you are able to palpate the impulse very well, and which is continuous with the apical impulse. Most likely, it is an RV the apex. And the third one is that as you track medially, the impulse dies out midway between the apex and the parasternal region, and to reach the parasternal region, you get the impulse again. That is usually biventricular. Both RV and LV are involved. So by doing a careful clinical examination, you can make out whether it is a LV apex or is it the RV apex or whether it is both RV and LV involvement. I want to ask you one more question. You mentioned about the epigastric pulsation. So your description is inadequate because epigastric pulsation may be due to the aortic impulse.
Due to aorta or liver or from RV, sir.
You have to make out how will you make out whether it's RV or abdominal aorta or pulsation? Unless you do it, you cannot be certain
Actually, sir, in this patient, his left lobe of the liver was enlarged. During epigastric.
More important is
No. Sir is asking you when you have got epigastric pulsation, Is it because of RV enlargement or is it because of aortic aneurysm
These are the
or
two
aortic
That,
pulsations?
that is depending on where we are feeling the pulsation when we are palpating, sir, with the finger. Depending if it is on the lateral edge of the um, of the finger, then it is more like originating from the liver. If it is on the underside, it is from the aorta. If it is on the medial side of the the finger, it like originates from the RBC.
Doctor, I will tell you. Say whether it is an abdominal aortic pulsation or whether it is a RV pulsation can be made out by 2 points. One,
Yes, sir.
you ask the patient to do an abdominal inspiration. When the abdominal inspiration happens, what happens? The diaphragm comes down, and what will happen to RV pulsation?
Yes, sir.
What happens to RV pulsation during inspiration? It will become more
Increase. It will more prominent, sir.
more prominent. What will happen to abdominal aortic pulsation?
Decrease.
It will become less
Decrease.
prominent. It becomes less prominent because of the abdominal distance, and the distance from the anterior part of the abdomen to the abdominal aorta increases, and the pulsation becomes less prominent. So during inspiration,
Yes.
if the pulsation becomes more prominent, it is RV pulsation. It becomes less prominent, it is abdominal aortic pulsation. Two, when you palpate and put your finger in the epigastrium, if the impulse is felt at the tip of the finger, it is RV pulsation, and if it is
Yes.
felt at the pulp of your finger, it is an
Yes,
abdominal aortic pulsation. You should be very clear about these things. Don't
Yes,
read about the. Okay, go ahead.
on auscultation, normal first heart and second heart
No,
sounds
no,
were appeared.
percussion. No, percussion. No, not enough. Do you think it's important to percuss in this patient?
Yes, sir.
Why?
To ascertain the heart borders and find out whether the like to confirm whether there's cardiomegaly and whether the left heart border is.
Don't beat about the bush. If you do not know, I will answer.
No. Second space
make out
percussion.
What?
Second space percussion.
What to make out what? What is the thing that you are looking for?
Dilated pulmonary arteries.
All right, pulmonary artery may not be grossly dilated, that we do not know. But something can be definitely dilated, especially the right atrium may be dilated because you are hearing a prominent deviation in the neck. You are suspecting tricuspid regurgitation, and right atrium may be significantly large, and you should percuss for the right border of the heart.
Yes, sir.
It's important to percuss. Did you do that?
Yes, sir.
Did you percuss the right border of the heart?
No, sir.
No, you should do it because
Yes.
you are suspecting tricuspid regurgitation, so the right atrium can be significantly enlarged and it can bulge beyond the right sternal border. Okay, well, of course, you can palpate the second intercostal space for the aortic pulsation as well as pulmonary artery pulsations. But in this particular case, you should definitely look for the dull node on the right side of the sternum, indicating right atrial enlargement. Actually, you should look for thrill in the right side of the sternum. Sometimes in patients with tricuspid regurgitation, you may be able to feel a thrill over the right atrium. And you should palpate for right atrial thrill in a patient with tricuspid regurgitation on the right side of the sternum.
Okay, sir.
Okay, go ahead.
Okay. On auscultation, normal first and second heart sounds were appreciated in all the areas. High-pitched, soft-blowing holosystolic murmur of grade 3/6 was heard at best at the left lower sternal border with diaphragm of the stethoscope with patient in the sitting position and breath held in inspiration. And this murmur was accentuated with passive leg raising.
All right, I cannot hear you.
What do you think is the cause of this murmur, holosystolic murmur?
Doctor, what do you mean by holosystolic murmur? It's not a correct term. What do you mean by holosystolic murmur? It's not a correct term. The terms are early systolic,
pansystolic,
late systolic, pansystolic. What do you mean by holosystolic? What do you mean by hollow systolic? Hello, doctor. I can you hear me?
Why do you think the murmur is pansystolic, and what is the cause of this murmur?
So based on the previous palpatory findings, and on this murmur, I feel it originates from the tricuspid valve, sir. Mostly tricuspid regurgitation.
No, see, you are not thinking correctly. You said that this is a pansystolic murmur. What are the conditions in which you can get pansystolic murmur? There are only 3 conditions where there can be pansystolic murmur. They are
Mitral regurgitation,
yes,
tricuspid regurgitation, and VSD, sir.
VSD. There are only 3 conditions. So
Yes,
here
sir.
you are hearing a murmur, pansystolic, according to a pansystolic murmur in the
Yes, sir.
parasternal region, increasing
Yes,
on increasing on leg raising. So all put together, there is no doubt that murmur that you are hearing is a tricuspid regurgitation. What is the
yes, sir.
difficulty? But I want to ask you a question. What happens to second heart sound in tricuspid regurgitation?
Yes, sir.
You said the second heart sound is normally split. Did you say that?
Yes, sir. Normal, sir. I didn't find it. It can be narrow split, sir.
Why?
Because P2 comes early, sir.
In tricuspid regurgitation, the second heart sound can be narrow split, single, or even paradoxical. Can you explain?
Because, sir, the P2 comes early, sir. There
Yes.
can be.
Yes, P2 occurs early because of the RV has got double outlet,
Yes,
one to the rim and other to the pulmonary artery, and so the RV emptying is occurring much earlier than the
much
LV
earlier
emptying,
than LV.
result in a early P2. So these patients can have, of course, if the tricuspid regurgitation is mild, then of course it can be normal split, but it can be narrow split, single, or even paradoxical split.
Now, I will ask you one question, Devarchana.
Yes, sir.
So long we are thinking that the patient is in right heart failure.
Yes, sir.
So there is pedal edema, and you said that JEP is also raised. So do you expect to get a pansystolic murmur of PR, which will increase on leg raising if the patient is in right heart failure?
Why the murmur is increasing?
It will on passive leg raising, the venous return will increase to the right side, to the right atrium.
That is correct. But if the patient is in right heart failure,
Professor is asking
you
you
have said
that whether how can there be an increase in the tricuspid regurgitation murmur in a patient who is already on right heart failure by leg raising? You have to give explanation.
So these are certain points you have to keep in mind when you are presenting your case.
And not only
your
that,
patient is only secondary PH is there and PR murmur there, it is okay. But once you have committed, your patient is in right heart failure. Already a failing right heart cannot accommodate this extra blood.
Yes, yes.
Okay.
And again, this patient is very unlikely to have a murmur because usually the
Patient
murmur
on treatment can have this patient on treatment if it is compensated, heart failure is already treated and compensated, then you can find it. Otherwise, in a frank heart failure, it should not be there because RA cannot accommodate more blood on leg rising or in deep inspiration. But if it is treated partially and patient is compensated and volume status is already tackled by some diuretics, and then you can present these signs. Otherwise, in a frank heart failure where suppose class 3 or class 4, it should not be there. But in a treated patient, you can find it.
Doctor, I am going to ask you a very tough question. It is a hemodynamic question. Can in a patient with right heart failure, significant right heart failure by leg raising, can the tricuspid regurgitation become less prominent? This is to test your hemodynamic understanding. The patient is in right heart failure, RV failure. You are raising the leg. Can there be a reduction in the tricuspid regurgitation? When the leg raises, what happens to the venous return?
Yes. You
Venous
tell us,
return
the right atrial
increases.
pressure is
So
increasing.
when the venous return increases, what will happen to
Right atrial pressure and right atrial pressure will increase. In severe heart failure, if the right ventricle is also not able to accommodate the blood, the right ventricular pressure will also increase. Both right atrial and ventricular pressure will be almost similar.
Yeah.
The regurgitation will be less.
So in a patient with significantly elevated right atrial pressure, when the RV contracts, actually the regurgitation may become less prominent, and sometimes you may not get even the tricuspid regurgitation has become less prominent. This can classically occur in a patient with associated tricuspid stenosis also. Patients with tricuspid regurgitation and tricuspid stenosis, when you do a leg raising or when you increase the venous return to the right atrium, there can be a reduction in the intensity of the tricuspid regurgitation. And in a patient with tricuspid regurgitation without pulmonary arterial hypertension, pan-systolic murmur is extremely rare. Usually it is only an early systolic murmur, very short murmur, not a long murmur. It is only in
Exactly. This is a very important point in this case, because we are expecting no pulmonary involvement here, no PAH.
Yes.
So this is primary TR, and to get a holosystolic murmur in primary TR is again very unusual.
No, it cannot happen. Usually it never happens. Usually it is only an early systolic murmur. Doctor, you should auscultate once more. Don't go to the patient with the preformed ideas. You should auscultate carefully, time it, and then present and explain it. So here, in a patient with organic tricuspid regurgitation with no PH, I would consider that pan-systolic murmur due to tricuspid regurgitation is extremely unlikely.
Okay, sir.
Okay. Okay, go ahead.
Based on the history, because the patient had given up, there was a past history of some kind of liver involvement. Because of a history of altered bowel habits and weight loss, we also examined the gastrointestinal system. On palpation, we found on deep palpation that the liver was palpable 4 centimeter below the right costal margin in the mid-clavicular line. It had a rounded edge, a nodular surface with firm to hard consistency. It was non-tender and it moved with respiration, and it was pulsatile in nature, and hepatojugular reflex was seen.
No, this is not how we palpate the liver. You should mention the upper border of liver dullness. Okay, that has to be mentioned. And hepatojugular reflux, you don't mention it here. You mention it in JVP.
Yes.
When you are getting the JVP raised, there is no point in mentioning hepatojugular reflux.
Yes, sir. Yes, sir. The upper border of liver dullness were palpated. It was in the right sixth intercostal space, sir, in the mid clavicular line, and the liver span was 14 centimeters, sir. From we were not sure whether to mention, so we didn't write it, but we measured it, sir. Upper border of liver dullness and liver span.
So, what are you hinting at by this finding? Are you
there was,
hinting that there is cardiac cirrhosis?
Hepatomegaly was
Hepatomegaly is there.
Can be congestive hepatomegaly secondary to right heart failure, or
But you have categorically said that this is non-tender.
Yes.
This is non-tender, na?
Yes, sir. Non-tender.
Usually, right heart failure brings about tender hepatomegaly.
Tender hepatomegaly.
And
We
not
can
even
This is a chronic
nodular
condition.
consider
You want
that
to
the
mean.
patient also had cirrhosis of liver, chronic liver disease. like malignancy or hepatocellular carcinoma, or if patient who like patient can be on treatment and like
What about nodularity of the surface? You have mentioned the nodules.
yes,
So you are hinting towards cirrhosis. This is not a normal liver feel.
yes.
Okay, go ahead.
How did you see liver, pulsatile liver?
Devarchana, you tell us the method. How did you see liver pulsality? One hand, two hand.
One hand, sir. Like
one hand in front, the other hand in the back.
Yes.
And with each beat, you will see expansile pulsation. But you don't get this finding in a liver which is firm to hard consistency. Firm to hard consistency liver does not have systolic pulsation. It's only a soft liver which has systolic pulsations. Okay.
yes,
So once cirrhotic changes have taken place, you cannot expect these kind of pulsations.
Can you hear me?
Yes, sir.
No, I wanted to actually my lost connection. I do not know whether it was discussed or not. In a patient with tricuspid regurgitation, as far as part of the cardiovascular system examination, what will you look for in the liver? You should look for expansive.
Yes, sir.
Hari is also asking you about hepatic pulsations. So you should say there is expansile pulsations, but you have already committed that the liver is hard or firm in consistency. So these things don't match. Did you look for shifting Dunless in this patient? Do you expect ascites in this patient?
Yes, sir. That's part. If patient is in failure, part of volume overload state, patient can also have ascites. Shifting dullness was not there, sir. It was absent. Patient
Are
had
you aware of a condition called ascites precox?
Yes, sir.
What is it and where does it occur?
Hello, am I audible?
Yes,
it occurs in constrictive pericarditis, sir. And it's like the ascites appears before
pedal edema.
pedal edema. Yes, sir.
Okay, can you tell us why ascites appears before pedal edema in constrictive pericarditis but not in other causes of right heart failure? In all cases of right heart failure, pedal edema comes first. But in constrictive pericarditis, ascites comes earlier than pedal edema. That is why it's got a special name, ascites precox.
So because of hepatic veins, like if there is constriction of the hepatic veins,
yes, there is selective engorgement of the hepatic veins which lead to exudation of fluid in the peritoneum. The IVC is not that much involved in the beginning. So this is one of the mechanisms of ascites.
yes, sir.
Sanjani, one question we shall ask. Is your case a high pressure tear or a low pressure tear?
Yes, sir. It seems like a high pressure tear only.
A high pressure tear. What is the point?
Hey, after so much of discussion, why you are bringing again high pressure tear? What is the cause of high pressure? You said there is no pH. Okay,
Sir, yes.
This is primary involvement of the tricuspid valve. That is why this is leaking. So how can a primary involvement of a tricuspid valve bring about high pressure tear?
No, sir.
So it
Only
is a
tricuspid valves. Yes, sir. Low pressure tier only.
Is there any thrill in the tricuspid area?
Sir,
No.
sorry, sir.
Was there any thrill? These are the common questions which we ask.
thrill. Did you get any thrill? You didn't get
No,
any
sir.
thrill, na?
There was no thrill, sir.
Where it is
Yes.
found? In which tier it is found?
Sir, in which
What,
tier
sir?
it is?
Which tier? High pressure tier or low pressure tier? Where do you find this thrill?
High pressure, we'll find. In high pressure, sir, we'll find a thrill, sir.
No, this is the reverse. Right, carry on. These are the questions we should ask in the exam.
Okay, sir.
Carry on.
And other systems, respiratory systems, there was bilateral normal vesicular breath sounds heard, and there was no central nervous system alert, conscious, oriented, musculoskeletal system, no significant abnormality. Genitourinary system not examined due to patient's request.
Okay.
So to
So-
summarize,
Yes, tell us the summary points and the diagnosis with modification. After the discussion, whatever sir has said, you have to modify. Don't keep on repeating what you have written. So,
so,
as
sir,
per discussion, you go ahead.
yes, sir. So this is a case of an 80 years old elderly male who was a known hypertensive, presented with easy fatigability, weight loss, and bipedal edema, with a history of abdominal pain and chronic diarrhea. On examination, he had bipedal edema, elevated JVP with prominent B wave, and expected rapid void descent, and a pansystolic murmur of grade 3 in the left lower sternal border.
No. You have to modify it, sir. What did we say? It's an organic TR. Very unlikely to be pansystolic.
High pitched pansystolic murmur of grade 3 in the left lower sternal border, which was accentuated on inspiration, and patient also had hepatomegaly. Based on these findings, I would like to consider the possibility of right heart failure, likely due to a valvular heart disease, in which mostly being a regurgitant lesion more than a stenotic lesion, and involving the tricuspid valve more than the mitral valve.
Why do you bring mitral stenosis here?
Exactly. This is my question also. Are we missing silent mitral stenosis in this case? Can it be? After all, we are missing the MS. Do you think that is a possibility?
No, sir. We don't think mitral stenosis should be brought in the picture.
Okay, this you should be very
The
careful.
upstream lesion will always influence downstream lesion. So if the TS is significant, the MS, it may hide the MS. So you have to be very careful, because rheumatic heart disease is the most prevalent condition in our country. And coexisting MS can always be there. And because of the so much involvement of the tricuspid valve, maybe tricuspid stenosis or tricuspid regurgitation, but these are all conjectures. So that may hide the MS. So that part is always there. But in examination, the apex was of RV type. You have got an murmur, the P2 is not loud, and all the findings are suggestive of a low pressure TR situation. So possibly organic tricuspid involvement is only there.
Okay,
so
sir.
that in the exam you have to clearly answer all these questions.
Yes, sir.
Dr. Professor Manjuran, have you got any question? Sir is off the line, na? Sir is offline. Okay, the time is short. You show us the investigations.
So this was a recent ECG done on 17th of August. It shows a normal sinus rhythm with no
So what are the findings you were searching in the ECG and it is not there? You tell us 1, 2, 3, 4. 4 salient
We are
points.
in case to confirm whether it's a like organic like to rule out whether there is any pulmonary
No, I am not
involvement.
asking all those things. Certain findings I would expect in this ECG, but it is not there.
Yes, sir.
So
We
tell
were
me about
looking
it.
for.
You see look at the right ventricular forces.
Yes, sir.
The right ventricular forces is not there at all in this ECG.
Yes.
There are no tall R in V1. Okay.
No.
Next, you look at the P waves. There is no evidence of P pulmonale
No
in this
evidence of
case.
pulmonary, sir.
Yes, because this is a right heart failure case. So I will look for RV forces here. I will look for P pulmonale here. I will look at the axis. Okay. See, axis is what? Tell me the axis. What is the axis in this ECG?
It's a normal axis.
Normal axis, sir.
Yes, I would expect also right axis, but
Right
that is
axis.
not there. The R wave progression is relatively good. Okay.
Yes, sir.
So one of you said amyloidosis in the differential diagnosis. So do you think any markers of
No, sir.
restrictive cardiomyopathy in this ECG?
No, sir. In amyloidosis, there is generally low voltage complexes. And
So don't you think this is a low voltage complex? You look at the
1 and 3.
yes, you look at the limb leads. Are their height more than 5 millimeter?
No,
Look
sir.
at the calibration. Look at the calibration. You have given the calibration.
Standard calibration.
So standard calibration only. Sir,
10
it
millimeter
can.
standard calibration. All the limb leads height is less than 5 millimeter.
Yes, sir.
Look at it.
Yes, sir.
Now, I am not saying it is there in the ECG.
Yes, sir.
So these are
It's there.
certain features you should discuss.
Yes, sir.
Okay, go ahead.
So limb lead, low voltage complex. Chest lead normal. What does it signify?
Sorry, sir. Limb lead low voltage
Low voltage.
complexes. And
Chest lead normal. What does it signify?
so there may be ischemia.
No. It signifies congested state. More so if there is QR pattern in AVR,
You are in
right? It is very characteristic feature of congested state.
Okay, sir.
If the reverse occurs, chest leads low voltage, peripheral leads normal. What does it signify?
So anterior wall ischemia.
No. You read
No.
it.
Yes, sir.
Carry on. Next.
I said this 2D echo of was of latest 7th
You are
February.
not going to show us the X-ray?
So
Chest
X-ray was not available. So X-ray we
Okay,
didn't have.
okay. Go ahead.
Yes.
But what are the salient points you want to look in the X-ray? X-ray is very important. The X-ray will show us no features of pulmonary venous congestion. Okay. The
Yes,
lung fields are supposed to be clear. And
Yes,
you
sir.
expect chamber enlargement in the form of RA enlargement.
RA, yes.
Okay.
Yes.
And in the lateral view, you should look for RV enlargement.
RV enlargement.
How much the RV is coming in contact with the sternum.
Yes.
And then in the lateral view, you should also look at the where the lower border is crossing the aorta. Okay. So these are
Yes,
all the features you should look in the X-ray. Anyway, proceed.
In
And also
2D.
regulatory. Right. Carry on.
Yes, sir. The in 2D echo, the LV ejection fraction was 55%. There was enlarged RA and dilated RV with good RV systolic function. There was no LV wall motion abnormality. Systolic function was also adequate. And among the valves, tricuspid valve, there was coaptation failure of the leaflets, dilated annulus with grade 4 regurgitation. Other
Pulmonary
significant
pressure?
finding. Estimated pulmonary arterial pressure was 40 millimeters of mercury, sir.
Right. Then
So there is no pulmonary valve involvement,
No,
only
sir.
PR.
Pulmonary valves are normal, sir.
Can you show us the curve, Doppler curve of the TR jet? And what will
Sir,
that suggest?
um,
Any
so in
comment
this
looking at the
patient,
Doppler envelope?
sir,
Tell us, you don't have to show, you tell us what you expect in the Doppler envelope. PR Doppler envelope. What is the normal envelopes looks like, what it looks like in PH, and what PR envelope you will expect in this case. If you are not aware, please read it. Okay.
okay, sir.
Okay, and then go ahead.
Because this patient had a past 10 years back a scan report of likely a liver lesion. There was like a query of atypical hemangiomas versus metastasis. Recently, he was under follow-up oncologist, so they were suspecting there might be a neuroendocrine tumor involvement. So HIA in 24 hours urine sample was done and it was elevated, sir, 34 milligram per, in 24 hours. And also chromogranin A was done, which was high. And DOTA PET CT scan was done, which showed somatostatin receptor expressing multifocal tumors in the stomach and small bowel, with similar somatostatin receptor expressing metastasis to mesenteric lymph nodes and liver. And he was advised for a biopsy from the liver lesion, and the biopsy showed that it was a grade 1 neuroendocrine tumor, positive for chromogranin, synaptophysin, and Ki67 or 2%.
so tell me the complete diagnosis now.
So this patient is a case of right heart failure due to tricuspid valve regurgitation, which is an organic in nature due to um, most likely carcinoid heart disease secondary to carcinoid syndrome as a part of because of an neuroendocrine tumor involving the gastrointestinal system.
Right.
Yes, sir.
What about PVH?
With liver metastasis.
Yes, sir, with liver metastasis.
Okay. Mention also pulmonary pressure and pulmonary venous pressure. Both are normal.
With normal pulmonary arterial, yes, sir, and venous pressure.
Yes, they mentioned that one.
Yes, sir.
Right. Short. We are using the time. Tell us the yes.
The further treatment, this patient was over the last 3-4 months, he was on diuretic therapy, with which his pedal edema had improved, and he was also on fluid restriction. Symptom wise, also, patient had improvement in his um, functional capacity. And patient was also started on somatostatin receptor analogs, that octreotide long acting, 30 mg IM injections monthly. Uh, uh, because of which he said that he certain his symptoms related to altered bowel habits like diarrhea and cramping, abdominal pain had significantly reduced.
Right.
Currently, patient is doing well with
Yes.
So this is your plan. You want to do a percutaneous tricuspid annuloplasty.
Do you know how it is done?
the
Okay.
therapy for the carcinoid analog as well as for the right patient is planned. Yes, sir.
Okay,
So that's all, sir.
that's all, na?
Yes, sir. Thank you, sir.
Suppose you want to place the case for surgery.
Yes, sir.
So will you prefer a bioprosthetic valve or a mechanical valve in this case?
A
Did you
bioprosthetic
follow my
valve, sir.
question?
Because
Bioprosthetic or mechanical valve?
bioprosthetic valve, sir, because tricuspid valve is of low flow, low pressure system. So mechanical valve will lead they might have more chances of thrombosis, sir.
What will be the fate of that biological valve with that agents? Bioactive agents will be there in the system,
Yes.
no? So there will be early degeneration of the bioprosthetic valve. It will be preferable for mechanical valve with anticoagulants.
Okay, sir.
Right.
And the best will be the percutaneous repair now. We can do it if the patient gets stabilized, and also from oncology clearance that the disease is under control, because
Yes,
this
obviously.
octreotide can reduce the symptom only. The disease control should be with some other agent or by surgery.
Yes, sir. Recently, the latest scan of 7th February, DOTA PET scan had shown reduction in the uptake of the somatostatin receptors, and it showed partial response.
Okay. If
Patient
it
has
is if responded well, then we can repair the tricuspid valve.
Yes.
Yes, sir.
Bioactive substances
Okay.
must be controlled.
Okay. Devarchana
Okay.
and Ranjini,
Yes.
both of
Yes,
you
sir.
have presented the case nicely.
Yes,
And I want to thank Dr. PC Mondal for selecting such a nice case and diagnosing it, because this is very difficult to diagnose.
Good.
Thank you, sir.
So
Thank
thank
you,
you
sir.
all.
Thank you for your
Thank
input,
you.
sir.
Thank you,
Dr. Mondal.
Kajol Ganguly sir. Thank you.
Yes.
I'll request
me here.
Dr. Ganguly sir. Sir,
Yes.
please post for one OSCE class, sir. OSCE. When in DNB they have to prepare for OSCE also. That is a part of examination.
Yes.
Dipankar has got good collection. If Dipankar can take a
Yes,
class
we are
on
doing. We
OSCE,
are doing everything in the physical. Last time you came to our physical meet, we show
yes, sir. Yes,
everything. We
yes,
show
sir. Yes,
everything.
sir.
We have oximetry, Dipankar showed hemodynamics,
Yes, yes, yes.
all those things. And the experts we call. They show. Because Dr. Narayan, P.S. Narayan has a huge collection of X-rays. It was
Yes,
very
sir.
nice. And we called that one, Hari Krishnan, for this hemodynamics. Because he is very famous for that. We plan all those things. Okay. We can
Okay,
show
sir.
in
Thank
this
you.
waste of time. Thank you, Dr. Mondal. Thank you, Ranjini Devarchana, for beautiful case.
Yes,
And
yes, sir. Thank you, sir.
and Dr. Ghosh Dostidar, and Sar is offline, Dr. Manjuran, for your contribution to this meeting. We shall have similar meeting afterwards also. With that, thank you all. Good evening to
Thank you, sir.
everybody.
Good evening, sir.
Thank you. Bye bye.
You have done reasonably well. Get prepared for the exam.
Yes, sir. Yes. Thank you, sir.